family, BMA Con, for giving me this opportunity. Uh, Definitely, I think cardiac is all about Jivan Marnata Prashna, and I think that spine is all about the quality of life. So we are becoming more and more important now. Everyone wants to be active, nobody wants to be bedridden. So why the spine surgery is becoming common in a younger patient? I think due to the lifestyle, they are landed, continuous sitting job, too much of travels. I think they are getting more and more disc herniations. So this is the younger population, and the other side is that the life expectancy has increased. So we are getting more and more older patients. 80 plus is now common, and they have started developing more and more spine problems. So that is how the spine surgery is becoming more common. So today my focus is on mainly the mechanical back pain, that is degenerative spine. So most of these, more than 95% cases, these are all related to the degenerative, that is मणक्याची झीज होणे किंवा मणक्यात गॅप पडणे, spondylitis. So this is very common. Again, degenerative condition, there are various terms. Just giving you a brief idea that common is a disc herniation. This is a disc which we can see. Then degenerative disc disease, canal stenosis, lumbar canal stenosis, slip vertebra. Then sometimes you get a scoliosis, that is a curved spine in the old age, flat back, that losing the normal curvature of the spine. And whenever these degenerative changes happen, these are the three main things: the facet joint, the disc, and the ligamentum flavum. So there's a covering of the nerves, then there is a joint, and then there's a disc. So all the three components, they causes the pressure on the nerves and causing the ultimately stenosis. There are a lot of pain generators in the spine, right from ligament, muscles, facet, joint, capsules, disc coverings, nerves. So there's too many structures in the spine which causes pain. Now, in general, any back pain patient or any spine, if you suspect spine disorders, broadly we can classify into the four categories. One is a real bad situation where we have a cauda equina, that is a pressure on the spinal cord, and there is a neurological deficit. Then sometimes spine infection, tumor, or fractures causing pressure on the nerves. Usually these patients need urgent spine surgery in most of these cases. The second thing is back pain due to the disc prolapse, stenosis, which is a very common condition. Usually what we say mankyat gap padne, G's, spondylitis, most of these patients come into this category. Maximum patient get treated with a conservative management. They always get better with medicine, rest, physiotherapy, doing some kind of exercises, changing the lifestyles. If it is not getting better or too much of back pain, leg pain, then we come into the picture, and sometimes we have to offer the spine surgeries. Non-specific back pain is where MRI, X-rays are not showing much problems in the spine. Usually the pain is related to the sprain, muscle spasm, or some ligament sprain. And on MRI the spine is looking normal. So usually these are the patients which are always treated with a proper conservative treatment, patient education. They don't need to take the complete bed rest, but they need to be active, and they should do regular exercises. And there are certain non-back reasons. There are abdominal organs, in females they have gynecological issues, or in males prostate problems. So that can also cause the back pain. These are the clinical syndromes which we usually see in the spine. Main is a low back pain, then sometimes the acute pain coming into the leg, we call this as a sciatica radicular syndrome. Then there are patients who have chronic pains whenever they walk, or they get that sciatica pain for a long periods. Then typical neurogenic claudication, they walk certain distance, then they have to sit down because they get heaviness, tingling, numbness in the legs, and they have to sit down for few seconds or minute, and then again they can walk. And obviously in severe old age cases we get a stooping. The posture becomes, due to the degenerative scoliosis or a flat back, we get abnormal postures. And giving rise to the lot of back pain or leg pain. Again, nerve distribution in the low back, I think I would just tell that above knee is usually the upper lumbar nerves, which usually can cause the problem, and in the below knee is usually the lower lumbar nerves, L5 or S1. Again, this is a disc herniation where you get a various types of disc herniation from center to the lateral area, and depends on the site of the disc herniation. A lot of time we have to decide what kind of surgical management is good for that patient. Again, similarly, the disc herniation where the disc fragment is come out and it's pressing the nerves. Lumbar canal stenosis usually in the old patients where they get a stenosis, the pressure on the nerves increase, the space of the nerves gets compromised, and then they start getting the neurogenic claudications. As you can see, there is a lot of disc bulges. The white thing which is going down is the nerve, spinal cord. So what is the daycare spine surgery? Now, we are, the spine surgery in last 2 decades has tremendously changed. Previously, it was all about where if you do the spine surgery, you will be bedridden for many months and you will not be able to do any kind of work after that. So that scenario is totally changed now. So the spine surgery is no more a salvage surgery. Now it is a surgery to give a quality of life. You don't need to be bedridden, you don't need to be restrictive in your daily activities, and you should be able to enjoy your life. So that is what is the aim of the spine surgery in current scenario. And that's why we are moving towards the daycare spine surgery, where we can discharge the patient within 24-48 hours, and there are minimally invasive endoscopic, microscopic techniques. So we don't need to dissect too much of muscle, joints, or we don't need to remove too much of bone. So we can get this patient immediately, the same day we can make them out of bed and walk around. And next day we can discharge these patients. So there are various ways which have developed. MIS is a minimally invasive spine surgery. Is a broad spectrum where you can do decompression, discectomy, fixation. You can put the screws through the holes. So all these things you can do now, through a minimally invasive approach. And why there is a shift is required, as I said, that if you reduce the, it's a win-win situation for the patient as well as for the hospitals. For the patient, obviously, if they small cut, less pain, no ICU, no infection, they can go home early, they can go back to their work very soon, within 1 week, 2 weeks. For hospital, the packages are there. So same day, 1 day or 2 day, hospital is charging almost the same way. So it is very beneficial for the hospital to promote the MIS surgeries. And we are following the ERAS protocol. This is a newer things where we, right from pre-operative to the post-operative, we are properly explaining the patient what is going to be there. So we are going to do certain tests, then we are going to admit, we are the operative time, then we expect you to walk around by evening or tomorrow morning, then we control the pain we do the pain management, we take care of the nausea, vomiting or any constipation during these procedures, we check on the vitals. So the purpose is to get admitted early in the morning, operate, and next day discharge the patient, walking, all the parameters are normal, they are going to the washroom and no constipation, no urinary retention. So coming to the spine surgery, now these are the basic things when we talk about a spine surgery. Discectomy is the most common, where we remove the disc fragment and free the nerve. Decompression in the old age patient, when we have a stenosis, we shave off the bone, we remove the ligamentum flavum, and sometimes we remove the part of the disc and we make some room for the nerves. Spinal fusion, when we have a severe back pain, we have an instability or too much of degeneration, we put screws, rod, and we fix it. Now newer things, disc arthroplasty, like a joint arthroplasty, we remove the disc and we try to give the motion to that particular segment. And scoliosis correction, these are the big surgeries where if you have curves to the spine, then we put screws, rod, and we correct this kind of spine problems. Again, overall decision making, that is how we follow. Less than 60, if no instability, only discectomy. If there is an instability, if there is a significant back pain, we tend to go for a fusion. Again, in old age, if there is no back pain, mainly claudication, no instability, we do only decompression. In again scoliosis cases, we have to judge clinically whether he has got only nerve related symptom or severe back problems. Coming to the discectomy, as I said, traditionally the open laminectomy discectomy, but now microscopic, endoscopic, or a transforaminal, where we just remove or 2 or 3 mm bone, we just burr it, we directly reach the site of the disc, we remove that fragment and free the nerve, and that's it. So we do not touch any other part of the spine, we do not destabilize the spine, and very next day we discharge these patients. So microscopic is still, with the literature, there is too much of literature because it's a very old technique. Last 2-3 decades we are using it. It's giving very good result. Endoscopic is similarly, there are 2 ways we can do the endoscopic. One is a posterior, where like microscopic, only with the endoscopic instrument, you can reach the spine through the posterior approach. And then there is a transforaminal, where you go from the side of the spine. If you have in a particular lateral disc herniation, then this is better than the posterior one. Decompression, again traditional, you remove the whole bone. You remove the mid part, remove the ligament, you remove the middle part of the bone, shave off, and you give some room to the nerves. In advances now, the keyhole means you just burr on the one side, and with tubes, when you change the direction of the tubes, you can reach the canal from inside, and you can remove the pressures from the, you can shave off the ligament, and you can make some room for the nerves. These are again things where mild to moderate cases, you can use some spacers to jack up that particular segment to decrease the stenosis level, but it is not indicated in severe cases. Coming to the spinal fusion, I think this is where we put the screws and rod. Before 2000, we used to have a posterolateral fusion where no implant, no screws. But now we are routinely using implant in each and every case. So we are not doing, without instrumentation, we usually not do fusion cases now. In fusion, there are various ways of doing it. There is an interbody, means between the 2 vertebral bodies, we remove the disc and we put a new implant, new cage, and we put screws and rod from the back. So there is a posterior, then transforaminal, anterior from the tummy, and then olive, that is from the lateral. We can go to the, reach the spine. This is a T-leaf, where transforaminal, you go from the side of the spine, you make some 1 inch, 1.5 inch incision on the either side. You reach the bone directly, through the holes you put the screws, you remove the disc, and you put a cage. So usually this patient, very next day we make them walk, and within 48 hours we discharge this patient up to 3 doses of IV antibiotics. Oblique lumbar, again this is something, if you have a scoliosis or a curved spine, this is an excellent technique where we go from the side of the tummy, retroperitoneal, we reach the disc level, remove the disc and jacked up that disc and maintain that, we kind of improve the curvature of the spine by putting those discs from the laterally. And then once it is, we put these cages, we put the screws from the back. So this is how this towers goes inside, and then we put the screws, and from the side we can put this cage. Again, fracture spines in osteoporotic old ladies. In the past, we used to open the whole spine, retract the muscles, and then we put the screws. Now we are not doing these kind of things. We are just putting directly, under the fluoroscopic guidance or O-arm, we directly find the pedicles, find that particular holes in the bone, and we put the screws. We don't need to cut anything. This is kind of towers which we put, and we directly put the screws over that. So we don't need to cut any muscles in this. Again, stentoplasty, osteoporotic vertebral fractures, where sometimes we can push some mesh and jacked up the body and fill that with the cement. So again, this is under local anesthesia. Only some sedation is given, daycare procedure. We do it in the morning, by evening we discharge. Coming to the disc replacement, I think this is something which is, we are trying to give some mobility to the spine and no fusion. But still the lumbar disc has some limitations because we cannot do in neurological cases or instability. So usually if you have only disc related problem, it is to be done from the front of the abdomen. Cervical disc commonly we do because neurological, any herniation, cord compression, still we can remove the disc and we can do the disc replacement. So summary, I think spine surgery is moving towards more less invasive, motion preserving and outpatient care. So careful patient selection, patient education, let them know what they expect and what is, we always follow this patient for 3 months after the surgery. It's not like 2-hour surgery and it's done. It is never like that. So we have a very close follow-up on all these patients first 3 months. So they should follow all the protocols which we have set. And usually we try to have their experience, throughout the experience should be a smooth one, right from pain management, nausea, vomiting, constipation, bladder, urinary retention, each aspect should be taken care of so that the whole surgery should be smooth for that patient. And ultimately, definitely we expect any patient, I always tell them that I expect that at the end of 1 month, they should be walking 30 minutes morning, 30 minutes evening. That is the aim of the surgery which we are doing. We never make the patient bedridden after the surgery. So that is what I think my message is, that spine surgery is all about improving the quality of life, and it is no more a salvage surgery. Thank you very much.